Hello, my name is Jessica Compton. Today we'll be discussing my practicum project. Included in today's discussion will be an overview of my selected topic, the lesson plan itself, and the training process, and we'll conclude with a summary of the efficacy of my training. I've been a behavioral health nurse for going on 9 years now. De-escalation training, in my opinion at least, has been underutilized and undervalued in nursing, especially when working with children. My practicum goal was to design, implement, and evaluate the evidence-based unit education module for nursing staff in efforts to reduce the number of physical holds or restraints seen on crisis mental health facilities. This was completed at Kempsville Center for Behavior Health in Norfolk, Virginia. As a behavior health nurse, you are responsible for many facets of patient care, to include supervision of the strategies and techniques of de-escalation used by staff, which I never understood why nurses are not trained in de-escalation in orientation. I was not trained in de-escalation. How are nurses to critique staff on their strategies or techniques used during de-escalation if we weren't trained ourselves? As we discuss my training, we will determine the efficacy by comparing the number of holds, my in-services, the feedback given from the nurses, and observations made. So my first objective was to obtain 5 peer-reviewed nursing journals related to de-escalation specific to children. After thoroughly researching, I found 33 and selected the best suited evidence-based articles and gave hard copies of 7 articles to my project mentor. My second objective was to write a lesson plan / training guide in service, utilizing common scenarios seen on a mental health crisis unit for children. I accomplished this by putting together a PowerPoint that served both as a visual aid during the instruction portion and then as a pace. My last 2 objectives were to review my lesson plan with a mentor and receive feedback. I met with my mentor and gave both a hard copy as well as an electronic copy via email to my of my PowerPoint. Revisions were made with the feedback given. Last objective of the design phase by obtaining approval from both the mentor and the managers in the department managers by submitting my lesson via email. During the implementation phase, was when I actually conducted the training. Just prior to my first in-service, I detailed a list of restraints that occurred in September, as well as up until the training started. My first objective in the implementation phase was to initiate the scenario-based de-escalation technique training over a week at the increase in the census and subsequently a higher acuity seen within the unit. Due to this, the availability of the nurses to attend were minimal, with averaging 1 to 2 nurses per session that were able to attend. To compensate for this, I completed 8 total performances to codes both before and after training. My second objective was to create a survey to have nurses complete in regards to the effectiveness of the newly learned de-escalation techniques. I produced and supplied, assessed the efficacy of the training. Nurses filled out the survey and at the conclusion of each in-service. I did receive some valuable feedback from the nurses, with the majority of them in favor to continue de-escalation training in the future. So during the training, The in-service began with an education portion, measures to use on the unit, a brief summary of trauma-informed care, and then both nonverbal and verbal techniques were taught. The education portion was followed by scenarios, both discussed, then acted on. At the conclusion of the training, nurses fill out the survey. So during the evaluation portion, my objective was to review and compare the number of restraints seen before training started and a week after, and then analyze that data regarding the effectiveness of the unit-based education. At the end of training, and obtained a new list to include up until the end of training. The restraint numbers were increased after training, but as we discussed earlier, so did the census. The census at the start of training was 55 patients at the end of training. So there was 12 holds from the 1st of October to the 17th of October. That's just prior to training. And then 8 holds in the whole month of September, the 18th to the 25th of October. The last objective was to complete a summary of the training, feedback given, and an overall finding of the project. Overall, the training was partially successful. The primary barrier to the success of a reduction of the unit itself. Just prior to training, the census, as we talked about, was low, and thus the acuity in turn was low. During the implementation phase, the census and acuity were dramatically increased. This not only caused an increase in the number of physical holds, but hindered the training itself. When comparing the physical holds alone, you would determine this training as a failure. However, this assessment is inadequate as a control, i.e. the unit, is vastly different prior to training starting and to the conclusion of it. To complete training at a predictably low census/acuity, such as in the summertime. Secondly, the training should include staff and nurses to be one is receiving the same training and are responding in the same manner. Thank you.